Fundación Cells. Renovamos la esperanza.
Welcome to this introduction to the exciting world of cell therapy. I'm Dr. Paul Winterton. I'm here representing Stem Cell Centers of Excellence. I'll be describing the state-of-the-art science and clinical application of stem cell therapeutics, particularly with regard to the orthopedic musculoskeletal realm of medicine. To begin, first, a little information about my background. I'm a native of Salt Lake City, Utah. I graduated from Harvard Medical School in 1993 and completed 5 years of orthopedic residency at the Mayo Clinic in Rochester, Minnesota, where I specialized in complex primary and revision joint replacement of the knee, hip, and shoulder. Following residency, I completed 2 fellowships at the Institute for Bone and Joint Disorders in Phoenix, Arizona. The first year fellowship included sports medicine involving reconstruction of the shoulder and knee. My second year fellowship included complex reconstruction of the hind foot and forefoot. In total, my training has included 5 years of undergraduate pre-med years at the University of Utah, followed by 4 years at Harvard Medical School, 5 years at the Mayo Clinic for orthopedic residency, 2 years of fellowship, and now 23 years into my practice. Interestingly, it's been a short 15 years that I've been exploring the exciting horizon of stem cell therapy and have just recently incorporated this technology in my practice within the last 5 years. We've all heard the words stem cell therapy, usually in the context of a new and exciting approach to therapeutic treatment of chronic disease. A lot of the media hype has been centered around the possibility of curing spinal cord injuries, paraplegia, quadriplegia, or you may have heard the possibilities of revitalizing the pancreas with insulin-producing stem cells to cure type 1 diabetes, or even injecting heart muscle for patients in chronic congestive heart failure. And finally, you may perhaps have sensed a social and political controversy surrounding the sourcing and procurement of stem cells, particularly with regard to embryonic stem cells. Well, during this presentation, you'll be relieved to learn that the current clinical applications of stem cell therapy are firmly sustained by a foundation of reputable humanitarian ethics and hard data from worldwide sources of scientific evidence and human trials. And although we'll continue marching toward the horizon of excellence in scientific discovery, we now have the foundation of science and data to aggressively integrate effective, efficacious therapeutic modalities based on the science of stem cells. By definition, a stem cell is a virtual infant cell that has the capacity to 1, self-replicate, and 2, differentiate or mature into a specific cell type, such as a bone cell, also known as an osteoblast, or cartilage cell, known as a chondrocyte. I'm not going to go into too much detail regarding what happens to developing embryos during the few days and weeks following conception. Those first cells that start multiplying are called pluripotential stem cells, meaning they have the ability to differentiate and transform into any part of the body. Then, as the weeks progress and the embryo begins to take form, some cells begin forming the rudimentary parts of the central and peripheral nervous system. Those cells are called ectoderm stem cells. The cells that begin forming the gut and the organs therein are called endoderm stem cells. And the cells that begin forming the muscle, fat, marrow, and skeleton are called mesoderm stem cells. So there you have it, Embryology 101. Each of our bodies have at their conception and development ectoderm, endoderm, and mesoderm. There, now that wasn't too painful, was it? Ectodermal, endodermal, and mesodermal embryonic development. Regarding stem cells that are used for the musculoskeletal system, mesodermal stem cells from marrow or fat are procured, harvested, and processed from marrow, fat, or muscle tissue. Some magazine or journal articles refer to these musculoskeletal precursor stem cells as mesenchymal stem cells. For the remainder of this particular discussion, we'll simply refer to them as stem cells. So, stem cells can be found everywhere. They exist in what we refer to as a quiescent or quiet state in different parts of our body. They can be recruited by some external stimulation like a traumatic injury, or activated by simple event of harvesting and processing outside the body. Sourcing the human stem cells for therapeutic purposes can be donated by the actual recipient or patient to be treated. These are called autologous stem cells and can be obtained from a patient's own bone marrow or fat deposits. The vast majority of therapeutic stem cells are allogeneic or allograft and are sourced from non-recipient humans. Within the realm of musculoskeletal therapeutics, these stem cells come from freshly harvested human placentas. The following description of sourcing human stem cells is the most important process for the recipient to clearly understand. As we proceed with this talk, you'll be relieved and reassured to know that the process of stem cell procurement is, first and foremost, ethically executed, and just as important, performed within the realm of utmost attention to detail and safety for the eventual clinical implantation or infusion. The vast majority of stem cells are obtained from the human placenta, processed no longer than 6 hours from the time of birth, obtained from only cesarean section births so as to maintain the highest standards of surgical aseptic technique, providing a sterile, non-contaminated source of stem cells. The woman donating her placenta has been declared perfectly healthy at the 6th month of pregnancy. Serological testing is conducted confirming negative status for HIV-1, HIV-2, hepatitis B, hepatitis C, syphilis, and Chagas disease. For the purposes of distinguishing a maternal stem cell and the maternal layer of the placenta from the fetal stem cells, only placentas from male newborns are obtained, as chromosomal DNA from mothers have 2 X chromosomes, and male babies have the XY chromosomal patterns. Therefore, the procured stem cells are confirmed to be fetal in origin from the portion of the placenta that is virtually part of the male fetus with only XY chromosomal patterns. Upon delivery, the placenta is placed in a sterile container and transferred to a laboratory where small specimens of cubed tissue are procured from specific regions of the placenta to optimize stem cell volume. What happens next in our state-of-the-art laboratories is performed the same way worldwide, based on the 2016 protocol published in the Journal of Developmental Biology entitled Isolation and Expansion of Mesenchymal Stem/Stromal Cells Derived from Human Placenta. Having pored over this protocol word for word myself, and having personally toured and participated in this protocol at the facility in Guadalajara, Mexico, I can attest to the excellence of the sophisticated staff and technicians. They are highly trained, brilliant scientists whose attention to detail is above reproach and adhere to the highest levels of scientific and ethical standards. The surgically obtained placental fragments are placed in test tubes in the presence of enzymes that begin the process of dissolving or dissolution of the parts of the tissue that do not contain stem cells. This particular procedure must be performed in a meticulous manner as to not compromise the vitality and viability of the stem cells. The process of cell preparation, washing, separation, non-cell enzymatic tissue digestion, and eventually cellular isolation is performed with both machine and manually mediated precision to optimize cell volume. Once the centrifuge pellet of precisely purified stem cells are isolated, the remarkable, magical culture and expansion begins. The process of culturing and expansion of the collected, thoroughly washed and isolated stem cells is perhaps the most fascinating part of this technology and likewise somewhat controversial. Why controversial? For decades, those of us in North America's scientific communities have been lobbying the American Food and Drug Administration for the permission to include this particular process as part of our clinical practices. Currently, in 2021, we have not been given the green light to perform ex vivo manipulation of stem cells that we've obtained. That is to say, American scientists and clinicians aren't allowed to culture and expand and replicate stem cells outside of the humans who are our scientific or clinical subjects. Current FDA-approved studies that are carefully and highly regulated may have exceptions for such ex vivo manipulation. However, there aren't apparent possibilities to open this technology to the general clinical consumer in the United States anytime soon. Remember, during the earlier part of this discussion, we defined a stem cell as having the capacity to 1, self-replicate, and 2, differentiate into many different types of cells. The final product of purified, isolated, washed stem cells are now ready for culture and expansion, or replication. Through a series of culture mediums and sequential transfer of cells to multiple purification transitions, the final expanded cells are, culture to culture, separated from any other contaminating cells that may have found their way into the final product. This is where the protocol engages perhaps the most high-tech machinery necessary to qualify and characterize the final product. The cell cultures are fluorescently labeled with antibody tags that only attach to specific cell types, a scientific process called immunocytochemical labeling. This procedure to perform this stem cell isolation is known as flow cytometry, and the machine that performs this function is the flow cytometer. The precise classification of each culture, namely the specific type of embryonic mesodermal mesenchymal stem cell, is identified for what type of tissue it will most likely migrate toward after infusion or injection. Once the stem cell has established close proximity to the target cell, it will then directly communicate with and begin the regenerative process with the target cells, a process referred to as the paracrine effect. Understanding the role of flow cytometry provides great credibility and is critical to establishing and preserving the confidence of the consumer. With the flow cytometer, we are able to clarify and qualify precisely what we'll be injecting or infusing into the recipient. Regarding quantification of cell volume and specific numbers, the experienced and qualified lab technicians are able to manually count via sophisticated microscopy and staining techniques approximately how many millions of cells are present in the final product. Following completion of processing, culturing, expansion, and isolation of the stem cells, sophisticated cryopreservation is utilized for storage purposes until the cells are injected or infused into the recipient. Personally speaking, I've recently completed and passed my 3rd series of board recertification examinations. They're administered by the American Board of Orthopedic Surgery. I've served on the committees that generate the board certification test questions, while a board member of the Board of Counselors for the American Academy of Orthopedic Surgery. I can credibly attest to the broad-based frustration the American surgical community is expressing regarding FDA regulation of this stem cell technology as a particular therapeutic modality. Currently, practicing clinicians in the United States are prohibited from performing ex vivo manipulation, culture, and expansion of procured stem cells. The political and medical community in favor of these restrictions claim that the clinical application of stem cell technology is outpacing our scientific understanding of cell biology and biochemistry. Speaking from personal experience, in April of 2021, I personally had the privilege of visiting and touring the Cell and Cells Time laboratories, clinics, and hospitals in Guadalajara and Puerto Vallarta. The University of Guadalajara affiliated labs and clinics are home to very sophisticated, state-of-the-art facilities necessary to advance the science of stem cell procurement and clinical application. During my visit, my procedure was performed by a board-certified, fellowship-trained plastic surgeon who had trained with and is in regular collaboration with the burn units at Boston Children's Hospital and University of Texas at Galveston. Guadalajara, a city of 9 million citizens, enjoys his expertise as he provides the highest world-class plastic surgical and burn management service. He performed the lipoaspiration procedure on my abdomen when my own stem cells were harvested, and was able to instruct me in the surgical protocol during the operation as I was awake, non-anesthetized, and very comfortable. Having obtained my medical degree after 5 years of Harvard Medical School in Boston, Massachusetts, and having completed 6 years of orthopedic residency and fellowship at the Mayo Clinic in Rochester, Minnesota, and having practiced for 25 years as a board-certified orthopedic surgeon and as a member of the Board of Counselors for the American Academy of Orthopedic Surgery, I know excellent clinical and surgical care when I see it. It was a privilege to be under the care and expert tutelage of the hospital and surgical staff at St. Javier Hospital in Guadalajara. This institution is renowned for its excellent care, staffed by graduates of the University of Guadalajara nursing and medical schools and surgical training programs. Indeed, necessity is the mother of invention, a well-known proverb from Plato, which means, roughly, that the primary driving force for new inventions is need. Critics of stem cell therapeutics complain that the practitioners of this new technology are exploiting the musculoskeletal pain experienced by the patient, implying some type of perverse incentives. The critics and skeptics complain that this empirical or anecdotal data, unreliably provided by patients and their treating physicians, are far outpacing the rigors of essential, necessary, scientifically provided data. They argue that before we send a stem cell into the tendon, joint, or bone passages, we must precisely understand the biochemistry and cell biology of how that stem cell interacts with cartilage in a joint or spinal disc. This philosophy, espoused by our critics, particularly those government officials within the Food and Drug Administration, the FDA, has had a remarkable, deleterious, and destructive influence on the momentum of clinical progress. If only they had applied similar logic to the development, launch, and broad-based distribution of opiates upon the pharmaceutical consumers of the world, we wouldn't be faced with the pandemic of opioid-related deaths due to the overdose, suicide, or the ravages of family dissolution due to divorce. The United States is at least 30 years behind the progress enjoyed by other developed countries in Europe, Mexico, and South America with regard to stem cell technology and its clinical application. To the hospital executives and CEOs of medical instrumentation companies, this technology is very concerning and, frankly, threatening to their bottom line. They have contractual relationships with designing surgeons and advocates of joint replacement, spinal surgery, and surgical instrumentation developers. Stem cell technology as a non-surgical therapeutic modality is viewed as a great threat to the profits associated with operative surgical practice and subsequent revenues generated. One need only take the necessary time and effort to assure him or herself of the efficacy, accessibility, and most importantly, the safety of this new, emerging, and exciting technology. Pain and the resulting functional limitations are clearly driving the demand for this particular technology. from arthritis to disc disease and nerve impingement of the cervical, thoracic, and lumbar spine to the joint, tendon, and ligament pathologies of the arms and legs. The world deserves to learn about and access all surgical and non-surgical solutions to these problems. As we've discussed thus far, to date in the United States, regulations do not allow for manipulation of stem cells following procurement. Any attempts to culture, grow, or expand stem cell volumes is against the law and would result in the loss of licensure of a practitioner who attempts to do so. Nonetheless, we are allowed to extract, concentrate stem cells from bone marrow or superficial fat stores from the patient. This has been performed very successfully for many years and has provided good to excellent clinical outcomes when the stem cells, following harvest, are concentrated, centrifuged, and injected within or around parts of the arms, legs, or spine that are the source of symptoms. The posterior pelvic prominence above the buttock is the most common site for marrow aspiration and can be performed in an outside clinical setting with very little pain. Likewise, fat stores superficially available around the flank, midriff, and buttock provide excellent sourcing of stem cells via the procedure called lipoaspiration. Following injection of minimally locally applied anesthesia near the bony prominence of the posterior pelvis or around fat or adipose deposits, large bore harvesters can be inserted into the respective bone and adipose, all performed with minimal and well-tolerated discomfort. High volumes of stem cell-rich marrow and fat stores can be centrifuged, providing a concentrated collection of stem cells and platelets for injection in and around the periphery of the spine or directly injected into the soft tissues and joints of the extremities. The stem cells procured and concentrated from bone marrow is referred to as bone marrow aspirate concentrate, or BMAC. In addition to the therapeutic properties of stem cells, the platelet-rich plasma, otherwise known as PRP, that accompanies the stem cells are teeming with 30+ growth factors within the alpha granules inside each platelet, possessing profound capacity to assist and augment the regenerative and revitalizing effects of stem cells. Good to excellent results have been reported far and wide and are being recognized by orthopedic and medical academies around the world as a credible, efficacious, and scientifically proven therapeutic modality. Barriers of such access to this technology generally lay in the lack of support from government or privately based insurance, thus requiring out-of-pocket payments. Regardless, even those subjects of modest means seek this efficacy-driven technology because it works. Finally, yes, platelet-rich plasma, or PRP, is abundant in stem cell concentrates procured from bone marrow, but PRP can also be obtained alone by simply drawing blood from the arm, just as anyone who donates their blood or provides samples of peripheral blood for testing. Quite simply, a significant volume of whole blood is withdrawn from the vein in the arm. The sample is then placed in a tube that undergoes high-speed centrifugation, where the plasma, platelets, white blood cells, and red blood cells are separated and then processed to provide a sample of highly concentrated platelets mixed with white blood cells. The red blood cell-rich plasma is isolated and separated from the white blood cell-rich platelet-rich plasma, or PRP. Remember, in our discussion, I described how platelets have microscopic compartments called alpha granules that hold over 30 specific growth factors that dramatically affect the regenerative and anti-inflammatory characteristics of the tissue within which it comes in contact. It actually makes perfect sense. If you are the creator or Mother Nature and you created a small structure called a platelet that homes in on areas that have been recently traumatized and may have active bleeding that need the clotting process pronto, you would also make little saddlebags called alpha granules filled with growth factors that start the transformative, regenerative healing process. Therefore, it stands to reason that given these truths about platelets, Why shouldn't we human beings harness, harvest, and concentrate the dramatic healing capacity of platelet-rich plasma and deliver it ourselves to the anatomic site of our choosing and deliver the regenerative, healing, anti-inflammatory effects to areas that tell us where it's needed most? The clinical outcomes reported in the orthopedic literature have been remarkably encouraging regarding the application of stem cell technology and its effective treatment of specific anatomic areas of the body. Since 2005, there have been great excitement and a clinical push towards this end. Let's take a moment and address different areas of the body that respond well to stem cell therapeutics. And as we discuss stem cell delivery, remember, PRP works right alongside the stem cells or can be procured by itself from the peripheral circulation. By the way, 1 week following the administration of stem cells to any part of the body, it is critical that regularly weekly follow-up occurs with the clinician who performed the procedure, not only for the sake of courteous follow-up, but to provide physical therapy and mechanical ultrasonic modalities that assist in the absorption and lymphatic dispersal of stem cells throughout the region of the targeted body area. Non-steroidal anti-inflammatory medications, or NSAIDs, specifically ibuprofen, Advil, Aleve, or naproxen, or aspirin, should be avoided for at least 6 weeks following treatment, as these medications can adversely affect the potency of stem cell and PRP activation. Tylenol, acetaminophen, or tramadol is appropriate to take immediately following the procedure. Finally, if the recipient has recently been treated with cortisone injections, they should delay stem cell therapy for at least 4 weeks. Spine problems involving the neck, thoracic, and lumbar regions have been traditionally treated with conservative management such as physical therapy, cortisone injections, or surgical modalities. The cartilage discs between the vertebral bodies, as well as the cartilage within the specific facet joints, can break down, become inflamed, and cause considerable pain, either from local irritation or compression of nerve roots that extend into the arms and legs. When these areas become progressively degenerative, the body opens up conduits of vessels called lymphatics to deliver naturally existing anti-inflammatory substances, also known as immunomodulatory proteins. Injecting stem cells near these lymphatic conduits or within a reasonable proximity can provide remarkable relief. Stem cells can home in and naturally migrate to these areas via lymphatic transport, so the actual disc or joint doesn't necessarily have to be directly injected, although under X-ray guidance, such direct placement of stem cells is routinely performed. Let's take a look at some examples of pre- and post-procedure responses to spinal pathology and the visible clinical and radiographic response to stem cell injections. Here we see the before and after response of bulging disc and its relieved compression of the surrounding nerve roots following stem cell therapy. Here we see the regenerative effects of stem cells directly injected into the disc. Again, some centers are providing X-ray and CT-guided modality intraoperatively to assist in precise local injection. However, remember, the stem cells and PRP can home in on the pathologic areas via the lymphatic conduits that surround the entire spine that can be accessed by simple local injection in and around the soft tissues of the posterior spine in the clinic setting. The exact mechanism of how the stem cell communicates with these degenerative cells is still the topic of hotly debated and rigorous scientific discourse. Nonetheless, when these infantile stem cells do come into close adjacent proximity to the older degenerative cells, biochemical and cell membrane outpouchings of the stem cells, known as exosomes, migrate toward and attach to and become part of the target degenerative cell. Many clinicians have described this mechanism as analogous to a little toddler that enters a room filled with 80-year-old people, and by simply being near the toddler, the old people become young. Exciting, isn't it? A veritable fountain of youth. Hyperbole or the truth? Many patients, in addition to local injections of autologous or allogeneic stem cells, choose to receive IV infusion of up to 100 million stem cells that flow to every corner of the body, thus delivering this regenerative, revitalizing capacity to every substance of our body. Of course, this is only available to patients outside of the United States who choose to have their own cells cultured and expanded, or receive donor stem cells from placental tissue previously described in this talk. I hope you're starting to see the vision and great capacity and options of stem cell therapeutics, from locally injected stem cells and PRP provided by the doctors in the United States, or donor stem cells available abroad that can likewise be injected in and around symptomatic parts of the body, all performed by board-certified, fellowship-trained orthopedic specialists. Having discussed treatment of the spine, we can now move to the shoulder. Issues of rotator cuff impingement, bursitis, shoulder separation where the collarbone meets the shoulder bone, and frank tear of the rotator cuff or biceps tendon. Physical therapy and cortisone injections have been the mainstay of non-surgical therapeutics prior to the advent of stem cell therapy. Here you can see an MRI rendering of a full-thickness rotator cuff tear that was treated with stem cell injection under ultrasonic guidance precisely at the site of the tear. Inflamed areas at the acromioclavicular joint, so common with weightlifters, can be treated with stem cells without any ultrasonic guidance. Injection directly into the joint for chronic arthritis or instability of the shoulder, ball, and socket joint is easily achievable with ultrasonic guidance. This graph demonstrates percent improvements in pain and function over time. And this is a fascinating graph that shows the superior outcomes with cultured and expanded stem cell preparations compared to non-cultured stem cells that have been simply centrifuged and concentrated. Tendons and ligaments and joints around the elbow are very responsive to stem cell and PRP injections. Tennis elbow on the lateral side, golfer's elbow on the inside and medial side, biceps tendon on the front, and triceps on the posterior side can be greatly relieved. Recently, the American Board of Orthopedic Surgery declared regenerative therapy as standard of care for tennis elbow over surgical management. Inflammation within and surrounding the carpal tunnel, involving the ligaments and tendons of the wrist and hands, can be greatly relieved by immunomodulatory, anti-inflammatory effects of stem cell injections. Patient testimonials have been very encouraging regarding the effectiveness of stem cell therapy for joints of the wrist and hand. Now, moving on to the lower extremities. Hip joint surrounding tendons and soft tissue, inflammation and bursitis around the hip girdle can be easily accessed with superficial stem cell injections or ultrasonically guided intra-articular injection into the hip joint for osteoarthritis or cartilage problems, thus providing great regenerative therapy for all of these anatomic sites. Mechanical problems around the SI joint are also easily accessible. Perhaps the most commonly treated part of the body is the knee joint, with the structures inside the joint itself, as well as the surrounding soft tissues. Here you can see the pre- and post-injection MRI images of a near complete tear of the ACL, that ligament, in this patient with acute instability. You can clearly see the remarkable regenerative capacity of the ACL tissues following ultrasonically assisted stem cell injections. Most regenerative stem cell therapy is focused on regenerating the articular cartilage defects, or, in other words, trauma to the surface of the bone, or stabilization and regenerative effects on the meniscus cartilage. Shin splints are common among the more active members of our population, with the inflammation at the attachment sites of our shin muscles and tendons that can be a great nuisance, if not incapacitating. Regenerative stem cell and PRP therapeutic injections can dramatically improve the symptoms at this site, as well as regenerate the chronically torn, inflamed tissues associated with chronic, repetitive pulling, tugging, and tearing at this site. The stabilizing ligaments about the ankle, the numerous tendons that traverse the ankle and foot joints, the ligaments that stabilize the ankle, and the cartilage surfaces of the foot and ankle are all vulnerable to acute trauma and chronic wear and tear. The regenerative and anti-inflammatory therapeutic applications at all of these sites provide great relief and successful clinical outcomes. In conclusion, thank you so much for your attentive thoughts and ears. I'm sure this discussion has spawned many questions and hope this presentation has clarified any concerns and has provided a clear picture of how stem cells and PRP are procured and how the clinical application of regenerative medicine is limitless in its capacity to treat many common disorders involving the spine and upper and lower extremities. With warmest and encouraging hopes toward your journey in harnessing the great power of regenerative stem cell and PRP biologics, thank you so much for this opportunity to give you this talk.
Fundación Cells. Renovamos la esperanza.